Good evening, and thank you for joining us for this exciting webinar titled Cardiac PET, Solutions for Adoption. My name is Phil Cranmer. I'm the Marketing Vice President for CDL Nuclear and will be your moderator this evening. We're delighted to see such a diverse group of attendees joining from all over the country. Today's session promises to be both enlightening and practical as we explore the world of cardiac PET. Throughout this webinar, we will not only delve into the clinical benefits and AUC of cardiac PET imaging, but also focus on practical solutions for adopting this technology effectively into clinical practice. Cardiac PET represents a pivotal advancement in cardiovascular imaging, and understanding ways to adopt and implement is key to delivering enhanced patient care and outcomes. If you have any questions throughout this evening's session, please click on the Q&A button at the bottom of your screen, and we will do our best to address them during the Q&A session at the end of the presentation. Thank you for being a part of this engaging session. Let's together uncover the pathways to adopting cardiac PET and harness the potential for improving cardiovascular health. I'm joined this evening by Dr. Vaskin Dilsizian. Dr. Dilsizian has been a professor of radiology and medicine at the University of Maryland School of Medicine since 2001 and chief of the Division of Nuclear Medicine since 2007. He served as the president of the Society of Nuclear Medicine and Molecular Imaging. He received the Herman Baumgart Award for his innumerable contributions to the science of nuclear cardiology. He served as the vice chair of Nuclear Regulatory Commission Advisory Committee on the medical uses of isotopes and was a member of the board of scientific counselors in the National Institutes of Health. He has published over 280 original peer-reviewed manuscripts, invited editorials and articles, 12 books, and 51 book chapters. It is also with great pleasure that I share that ASNC has named Dr. Dilsizian as the Mario Verani Memorial Lecturer for ASNC 2024, which is one of the highest honors bestowed by ASNC. The award recognizes qualities exemplified by the late Dr. Mario Verani, a founding member of ASNC, and a leader who inspired a generation of nuclear cardiologists. Congratulations, Dr. Dilsizian. Our final speaker is Brendan Loisel. Brendan is CDL's Chief Business Development Officer. Brendan will focus on the adoption of cardiac PET by highlighting three distinct solution models. We at CDL are confident that the solutions we'll soon discuss, custom PET suites, mobile rubidium, and mobile trailers, will effectively address a wide range of adoption concerns and barriers associated with implementing cardiac PET imaging. So without further ado, I will turn it over to Dr. Dilsizian to kick us off.
Thank you very much, Phil, for the very kind introduction. It's really a pleasure to join you all to discuss the exciting area of cardiac PET imaging. As you all know, the field began back in 1973, so it's nearly 50 years now, and we are entering the new era of advances in cardiac PET imaging, there's been exciting areas of instrumentation advances, radiopharmaceutical advances, software advances, and we are at a point where we are now providing high-quality images and physiological quantitative data that impact patients' diagnosis and prognosis. Obviously, I'm a consultant to CDL, but I will not be discussing anything that's not FDA approved. Let's talk about AUC, or appropriate use criteria. It was established by CMS, and the vision was that we needed some type of a clinical guidance document that can contribute to further optimize patient care and cost effectiveness in the healthcare system. And the thought was that if we have this document, we can now disseminate it to all relevant stakeholders, including referring physicians. And by doing so, we're going to be able to improve patient healthcare. And so the Society of Nuclear Medicine and Molecular Imaging was designated as a society that can come up with AUC guidance. And I was participating with my colleague, Dr. Schindler, and many other preeminent investigators in the field. And what we did is we came up with these 12 options of criteria. And perhaps, Phil, you may want to take over because the slides are not moving. I'm going to give you the control.
Dr. D, just try, that was my fault. Just try requesting control once more.
Okay.
Okay.
Thank you. So we came up with 210 clinical scenarios where PET would be indicated. And in those scenarios, we were able to determine whether PET was appropriate, grade 7 to 9 grades, may be appropriate, grades 4 to 6, or rarely appropriate. And again, of all these conditions that's outlined here, I'm going to be talking about symptomatic patients with suspected known CAD, which is number 1. And also I'm going to talk about those with microvascular dysfunction, which is where PET is very unique in identifying for all other imaging compared to other imaging techniques. For the section 1 criteria for the symptomatic patients with suspected or known coronary artery disease, you can see that if the patient can exercise and the patient has normal EKG, you don't need to do PET because PET is done with pharmacologic vasodilation. However, if the patient has abnormal baseline EKG and or cannot exercise, PET would be highly indicated. Now, what's interesting is that CMS put in these quality measures to be the goal of whatever imaging technique or whatever study we're doing, and they defined as it has to be effective, safe, efficient, patient-centric, equitable, and timely care. And on the right-hand side, I listed all the characteristics of PET that meet all of these CMS quality goal criteria. Effective, high diagnostic accuracy. It has the highest diagnostic accuracy when compared to treadmill or even SPECT imaging in the 90% range. Safe, it has the lowest radiation exposure compared to SPECT radiotracers, approximately 2 millisieverts when you use rubidium. Efficient, it can be done in a very short period of time, 5-minute image acquisition, and within 30 minutes, the entire study is done. You can provide the report officially within 30 minutes. Patient-centric, it accommodates ill, high-sick, large-body diabetes patients. It does not discriminate thin, sick patients from large patients. And with robust attenuation correction, we won't even know what the patient's body habitus is. Equitable, again, independent of the patient characteristics. And timely care, it's done, as I said, within 30 minutes. So now let's go back to our purpose of why PET imaging would be useful. Now, this is a cartoon diagram of what a coronary artery would look like, just to remind us all that the coronary arteries are not simple pipes. They're very dynamic. They taper down from the conductance vessels, which is where the atherosclerosis develop, down to resistant vessels, which is the arteriolar system. And as we develop atherosclerosis, nature has put in place this beautiful compensatory mechanism of vasodilation of distal resistant vessels where you maintain blood flow. Of course, that's the reason why many, many patients are walking around with atherosclerosis. They're not having chest pain. That's because the beautiful compensatory mechanism that's in place, along with collateral formation. Now, when the compensatory mechanism is maximized and such that the reduction in blood flow cannot be improved, that's when patients develop chest pain with exertion. And so our practice, as you know, is to study perfusion imaging under resting condition and then repeat the study under stress condition. Now, in this cartoon diagram, where let's say this would be the left main, circumflex, and LAD, and this is a short axis slice of the ventricle, you can see that even though there is critical stenosis in the circumflex territory, under resting condition, when the patient is not having chest pain, when you inject a radiotracer, there will be no perfusion defect. However, when we exercise the patient or do pharmacologic vasodilation, we augment blood flow by 2, 3, or 4 folds, where the normally the patent vessel would be able to increase blood flow to the myocardium by 3 to 4 folds. In contrast, the area of stenosis, while will increase, as shown here, it will not increase blood flow as much as the normal territory. Again, this is the visual interpretation, reversible perfusion defect, and above it are the quantitative absolute blood flow values. In blue, resting blood flow in the normally perfused territory and even in the area of stenosis are equal and normal. However, with stress, while we are able to augment blood flow in the non-occluded coronary artery, the augmentation is limited or attenuated in the area of stenosis, thereby creating this perfusion defect. And so based on that concept, if now what we are used to looking at SPECT imaging, you'll be looking something like this. And SPECT has worked for many years and continues to work after so many decades. And here's an example of a patient where you have extensive reversible perfusion defects in the anterior septal, anterior lateral, anterior apical, and they're all reversible, and there's cavity change, and it looks great. The images look a little bit fuzzier than what we'd like, but the information is there. But it's all visual and no quantitative data. Now, with PET imaging, which is, again, this is an example, a typical example from my lab, not only the images are very high quality, high resolution, but they're all attenuation corrected. So I don't have to apologize or guesstimate whether there's breast attenuation artifact or diaphragmatic attenuation artifact. I will look at the images and I won't even know if this patient has large body habitus or thin or cachectic person. My interpretation will be completely focused on what the distribution of perfusion is in vascular territories and various myocardial regions. Now, we take this visual interpretation and we say, how does coronary flow reserve or myocardial flow reserve help? Again, we have shown here 6 examples of coronary artery atherosclerotic variants. And on the right-hand side are the coronary flow reserve measurements. Now, what is coronary flow reserve? It is simply a ratio of hyperemic blood flow with vasodilation divided by resting blood flow. And usually resting blood flow is 1 cc's per minute per gram. Now, of course, anytime I give you a number, you know that there is error of measurements and physiological variation. Therefore, if I say 1, it ranges from 0.8 to 1.2. So if resting blood flow is 1, their flow reserve and stress flow will always be equal. So just remember, as long as your resting flow is normal, flow reserve and hyperemic blood flow are the same. So now let's go look at an example number 1, where there's no coronary artery narrowing at all. The conduit is open. The flow reserve is 4, meaning that hyperemic blood flow with vasodilation increased 4 folds higher than resting flow, which would be 1. The second would be an area of critical stenosis. And you can see that flow reserve is only 1, meaning that if the resting flow is 1, stress flow did not change much. It remained 1. So it's attenuated, and that's critically stenosed coronary artery. Now, I don't want to go through all of this, but you can understand that there will be conditions where you have 60% stenosis or 67% stenosis, but the flow reserve is okay. So why would we want to put a stent in here if the myocardium with hyperemic or exercise is showing improved blood flow? No reason to do so. And so the physiological information is adding value to the anatomical information that we do in the cath lab. And number 4 is a very, very nice example where the coronary angiographer will say, well, there is nothing no significant stenosis to put a stent in, but yet the patient has abnormal flow reserve. Patient has symptoms. So just because you can't put a stent in does not mean that the patient doesn't have chest pain or does not have any abnormal flow reserve. So again, complementary information to the anatomical information. So I'm going to show you some examples here. This is a patient with a normal study. And you can see that, again, resting flow is near 1. And you can see that there's very nice hyperemic response to vasodilation. And because this is 1, the hyperemic blood flow and the flow reserve numbers are the same. And therefore, this would be adding value to your visual interpretation by saying that the quantitative values of hyperemic flow reserve, hyperemic blood flow, and coronary flow reserve confirm the visual interpretation. Here's an example of a patient where you can see that there is classic LAD hypoperfused territory here. And you can see that in the LAD territory, hyperemic blood flow and flow reserve did not augment much, in contrast to the circumflex and RCA territories where there was a significant improvement with hyperemic vasodilation. Again, added value to what we see visually. This confirms that that's what we are seeing. Again, this is another patient with multivessel disease. And in this case, you can see that the resting blood flow is high. Now, why would we get a high resting blood flow? Well, you can get that with patients with concentric LVH. You can see the ventricle the myocardium is very, very thick. And that's commonly seen with hypertensive patients, hypertrophic cardiomyopathy, patients with chronic renal insufficiency end stage. Now, the resting flow is high, but hyperemic blood flow doesn't change much compared to the resting flow. Therefore, the ratio is near 1. So there are 4 potential explanations for this finding. Number 1 potential explanation is that you have balanced reduction in blood flow, meaning that all of these territories have 80 or 90% stenosis, and they're equally reduced, and that's why they're all abnormal. The other possibility is that the patient had a cath and does not have epicardial coronary artery disease, but this patient has, therefore, microvascular dysfunction. The third possibility is that the patient actually had caffeine the day of the study, or has xanthine medications, which are used as an antidote to vasodilation. Now, if I did not have this quantitative data, I would not be able to know, like with SPECT imaging, whether the patient had attenuated response during stress. I would simply say, well, it's a normal study. Well, maybe it's normal because the patient had caffeine that day. Maybe it's normal because the patient has xanthine medications on board. Or maybe it's normal because the patient has balanced reduction in blood flow. Or maybe because the patient has microvascular dysfunction. And I cannot tell any one of those with SPECT imaging alone, yet the quantitative data adds significant value to what I will be reporting to my referring physician. So I just mentioned about the caffeine intake, and I wanted to say that visual interpretation is relative. And what we do with stress imaging is that if the patient is on caffeine, you simply ask them to come back and repeat the study without caffeine. Now, sometimes, rarely, you have a genetic polymorphism of adenosine receptors, such that the patient doesn't respond to adenosine or persantine, but they may respond to dobutamine. So that is rare, but it's something that you can think about if others are not in the differential diagnosis. Now, here's an example of a patient where you can see a bullseye with SPECT imaging color pattern. Green is relatively decreased compared to the yellow and red. And you say, well, clearly this is an LAD territory perfusion defect. With quantitation of PET, you can see that the LAD territory flow is 1.37, which is clearly abnormal. You'd like it to be at least 2 and above. Circumflex territory, which is yellow, looks relatively normal, but it's 1.65. It's not normal. And my reference region, what looks beautiful and red, relatively speaking, is better. 1.9 is better than 1.65, better than 1.37, but certainly that's not normal. So with SPECT imaging, would say this patient has single vessel LED disease. With PET imaging, we'll say the patient has three vessel disease, worse in the LAD territory. This patient refused to undergo bypass surgery. He was very afraid of surgery and decided to undergo risk factor modification, an exercise program, and came back about a year later. And you can see that from baseline, if this was a SPECT study, you would say, well, the LAD territory is better, and whatever you're doing, continue doing so. In quantitative terms, you can see that all of these hypertonic blood flows have normalized in this patient. So this is a very reassuring data because it tells us that PET imaging can also be used to monitor medical therapy and exercise programs, which is where the field is going. We are no longer going to be putting stents and doing angioplasty in everybody. We're going to be thinking about more medical therapy and therapy of the entire body, renal atherosclerosis, peripheral vessel disease, carotid disease. So it's not enough to just put a Band-Aid in the LAD vessel and say, go enjoy life. We need to make sure that the patient changes their habits, their diets, their medical therapy, their exercise program, so that we can accomplish what we have seen in this particular patient. Again, what technique can do this? PET imaging. Now, this is consistent what the field of cardiology is moving at. In 2007, you all remember the COURAGE trial, which was over 2,000 patients, studied stable coronary artery disease patients who were suitable for angioplasty, but they were randomized to medical therapy versus angioplasty. They excluded, obviously, patients with significant proximal LAD disease or left main. When you follow these patients on medical therapy versus angioplasty over a 7-year period, you can see that the lines overlap, meaning that medical therapy does improve symptoms and does improve life equally as angioplasty in a certain subset of patients with appropriate coronary anatomy. In the FAME trial, we've learned that anatomy alone doesn't have the best outcome. It's the fractional flow reserve guided PCI, which is equivalent to our myocardial flow reserve or coronary flow reserve guided angioplasty, is what makes prognosis better. So we have finally convinced our interventional cardiologists that physiology trumps anatomy, and that physiology should be considered as a complementary information, not as a duplicate information. And so we are changing, therefore, management of coronary artery disease for purely anatomy, cath and stents, to that of anatomy plus functional imaging to determine which patients will benefit from revascularization. That's a huge, significant paradigm shift in managing patients with coronary artery disease. So when we are therefore in the field of nuclear cardiology, would like to transition from SPECT to PET imaging, not only because of the technology is better, images are better, the diagnostic accuracy is better, but then we are now entering to the world of quantitation. From being primary qualitative or semi-quantitative with some stress score to pure absolute blood flow measurements where we can identify multivessel coronary disease and monitor response to lifestyle and risk factor modifications and therapeutic interpretations. So again, when you look at the absolute blood flow measurements, it adds incremental value to some stress score that we do with SPECT imaging. The worse your blood flow, the higher the cardiac mortality. So in conclusion, why PET-CT? Many, many reasons. Let's just go through them very quickly. 1, absolute blood flow measurements. 2, higher and highest diagnostic accuracy that we have in nuclear cardiology. Relatively low radiation exposure down to 2 millisieverts. Short 5-minute image acquisitions. The entire study with rubidium is done in 30 minutes. It can be completed and interpreted on a timely manner. It accommodates ill patients, large body habitus patients, soft tissue attenuation, large breasts, big diaphragms. It doesn't matter. Soft tissue attenuation will take care of it. Oh, by the way, we can also look at the coronary artery calcification with the CT portion of the PET CT, which is used for attenuation correction. We can also identify the non-responders to vasodilator stress, those who were on caffeine, those who are on xanthine-derivative medications, which we would not know if we did not have the absolute blood flow measurements. So, in summary, quantitative myocardial blood flow assessment of PET identifies multivessel CAD and offers the opportunity to monitor responses to lifestyle and risk factor modification, as well as therapeutic interventions. Thank you very much. And I look forward for the question and answer period. Brandon will be discussing next solutions to adoption, and I will be giving the control over to him.
Thank you, Dr. Dilsizian. While I'm requesting control, I want to say thank you to you for your time here, and also to ASNC for hosting this webinar. And I want to give another shout out to ASNC and just point out that their support of cardiac PET, and by extension their member groups, is in no small way a reason why this modality is flourishing as it is today. So thank you for that. I'm here, as Phil said, on behalf of CDL Nuclear Technologies. We heard Dr. D talk about some of the clinical considerations of cardiac PET, and hopefully he was convincing. It's a test we certainly believe in here at CDL. If you're on board with the fact that PET is the right test in a wide range of cases, then we're here to tell you about some of the ways that we want to help you get involved in the modality, maybe for the first time, maybe to expand your access to the modality to more patients and more of the areas that you serve. So a little bit about the company. We've been in business now for almost, well, a little over 30 years. We were in advanced diagnostics the entire time. We've been in cardiac PET for about the last 14 years. And we've been very fortunate to participate in this upswing. We are looking forward to servicing here in the next year or so. We'll be up to 150 or so PET and PET CT systems in the ground throughout the country. So talking about the upswing in PET, we've been tracking these things, of course, as a part of our business. And, the tailwinds for this modality have been incredible. When I first got started about 10 years ago, we were having to really do a hard sell to a lot of groups to make them believers in the modality. And then, of course, the payers weren't always on board. And so we were duking it out with them. And I can tell you, over the course of the last 10 years, with, again, the support of groups like ASNC, we have been able to really raise the tide of this modality. We've been helping a ton of people, of course, through the groups that we serve, and we're proud to do so. As we look ahead into the latter part of this decade, I think things are going to continue as they have been. We're predicting pretty robust growth in the modality out past 2026. So no significant headwinds, I think, that would inhibit anybody's ability to adopt this modality. We also have robust societal support. This is a preferred or a recommended test in almost every case. So again, ASNC and SNM have been great supporters of the modality. Also, the ACC has designated it as a Class 1B test, which also helps certainly your case in prescribing this with any of your payers. Talking about the payers, so Medicare, since the beginning, they set up an incentive structure, frankly, that kind of helped along the modality from its infancy to where we are today. As long as I've been involved in PET, their policy has been do a SPECT or a PET. You can even do a PET after a SPECT study that was found to be inconclusive. So Medicare has always been on board with this study. And as I indicated, a lot of the privates have followed suit. So at CDL, we started out in cardiac PET primarily with some of the larger cardiology groups that we were already servicing with first pass imaging. If any of you remember that modality, certainly we were doing a lot of SPECT and echo at the time. And, there was a certain demographic of group that was right for cardiac PET at that time that made it such that you really couldn't get into some of the mid and small groups in the country. Just these barriers that you see here to adoption were oftentimes too great for those groups to overcome. And that was something that, we sought out pretty early on to fix. Again, we knew that this modality was going to be a game changer from our experience in PET. And then from some of those early adopters that we partnered with, the feedback and the patient results were just phenomenal. And so we set about to really figure out what we could do to help facilitate more widespread adoption. And what we came up with were these three models that you have in front of you here. So we've got solutions for folks that don't have a camera and need a camera. We've got solutions for folks that maybe do have access to a PET system or a PET CT system that perhaps is underutilized and can free up some time to add cardiac. And so we'll talk about more of those in greater detail right now, starting with our fixed site solution. So these are custom PET CT solutions. Almost all of what we do right now is PET CT, by the way. I think the standard of care is starting to move towards PET CT. Certainly PET is a viable choice, but and in some states you do have to do PET, but in most states we're installing PET CTs now, usually new systems. And we have a full team of folks that get in there that run the project for you from start to finish so that you can go about running your business or running your practice. And then hopefully in about 180 days, you come in and you're ready to get your training and you're started in cardiac PET. We want it to be about that easy for you. Along the way, while we're getting started up, we're working on things like licensure, accreditation. We're working with your township or your municipality to get your CO. And then after you've gotten started, we're going to work with you to make sure that you're getting appropriate reimbursement, prior authorizations are going through okay. We have a whole ecosystem that does radiology overreads, prior auth assistance, all sorts of things to make sure that you are able to offer this test to all of the appropriate patients. And recently, we just rolled out a mobile cardiac PET solution, pardon the pun. This is something that we actually have been doing for years, but just again, kind of reading the tea leaves here, for the folks that really want to get into cardiac PET, sometimes space is going to be the issue for them. And so we wanted to have an option for those people who maybe could find a place in their parking lot for a pad and they had the power hookup, and then we just bring the full lab right to your door with staff, with everything you're going to need to do cardiac PET the day that it shows up. Attended with the mobile service is everything that you see here. So just think of it as, a full services solution. So again, we don't want you to have to bend over backwards to get into cardiac PET CT. This is something that we want to have, you basically not worry about when you sign up with CDL. You know that you're getting the best equipment, the best training, the best support, the best staff, the full nine. In addition to those services there, we're also going to work with you to integrate with your PACS so that the images are transmitted seamlessly to you wherever you want to do your reads and into your EMR. Quick glance inside the trailer here. This is, a snapshot or a side view of what the trailer would look like. Just take note, there is a patient prep room in there. There is a hot lab in there. So that means that your patient workflow is going to be pretty seamless. So we'll work with you on developing that workflow, but pretty much everything is going to take place inside the trailer. So you can kind of get patients into the prep room, then they go to the camera, the next person comes into the prep room, and you kind of go through your day like that. So if you have high volumes, you can certainly get through a good number of patients in a given day. Some of the siting requirements are there on the left. Again, you don't have to worry too much about that right now. It's good to see right there if you happen to know what your facility has, but just talk to someone from CDL. Again, we have folks that have been doing this for years and years. They've done a number of sites. They know this stuff like the back of their hand. So they're going to get in there, they'll walk the site with you, and they'll tell you just what it will take to get started with the mobile unit. There are a few things that the customer is asked to provide, and so those are listed here. And generally those are going to be things that are kind of like disposable items. Obviously, we need physician readers. The crash cart has disposable pharmaceuticals on it. So I think fairly typical things that most of you will already have in your office will be provided by the customer on the trailer. And then our last solution here, we call it CardioNavix. This is our mobile rubidium solution. It's the first and only patented on-demand, we call it on-demand mobile solution. We partner with Bracco Diagnostics for this. So if any of you have, looked around a cardiac PET before, you've probably come across Bracco Diagnostics. They are far and away the largest.
Would you like to offer cardiac PET?
Hang on.
But aren't
far and away the
like
largest
to offer
provider of
cardiac PET?
rubidium, and this thing's just going to play, I guess. Okay, stop. Bronco Diagnostics and us partnered up to provide their infusion system on a mobile or an as-needed basis. So again, this is the solution. If you already have a PET CT at your office, we'll come in on 1 day a week, for instance. You do the patients, and then we take the generator out. And here's this video I wanted to play for you. It says it better than I can. So just for 1 minute and 30 seconds, here is a nice synopsis of it. Okay, hang on 1 sec.
Would you like to offer cardiac PET, but aren't sure how or where to begin? Does your institution have a PET or PET CT camera that you could access, but you don't have access to a rubidium generator, or thought it was too expensive to acquire one? CDL Cardionics has the solution. Cardionics is America's only provider of on-demand rubidium isotope for cardiac PET. Our fully licensed patented technology lets us bring a rubidium generator into your lab only on the days you need it. This means your lab doesn't need to commit to a costly full-time rubidium generator. Cardionics makes offering cardiac PET simple, convenient, and economical. Our program allows you to scale according to your patient volume needs. Improve the utilization of your existing PET or PET CT camera. Improve your operational efficiencies, and most importantly, deliver the highest quality cardiovascular imaging to your patients. Cardionics means accessible cardiac PET for everyone. Here's how it works. Just schedule which days you want to have a rubidium generator available. Our team will securely deliver and set up the rubidium generator with infusion system before your clinic opens. After your imaging day is complete, Cardionics will return to take the rubidium generator away until your next day of service. We offer flexible scheduling, including weekends and on-site clinical support and training for physicians and staff. We make getting started in cardiac PET simple and hassle-free. CDL Cardionics. You can perform cardiac PET whenever and wherever you need it.
So there you go. In a nutshell, that is the program. You have the camera, we bring the rubidium, you do patients, we take the rubidium away. Obviously, it's generated on site by the infusion system that you see here in front of you. And so it's really that simple. There's a picture of the van there. So that whole contraption, our device with the infusion system inside it, weighs about 1,000 pounds. So we wheel it in and out, as you see there. Handful of program considerations. There's a wide range of practices that would be appropriate for this. Again, if you have the camera, you have the ability to perform between 8 and 96 cardiac PET studies a month. Again, wide range, right? If you want to do once a month, that's great. That's 8 patients. If you want to do twice a week, that's also great. You could get up to 96 potentially if you do that. We do rely on your staff, and we will train them very thoroughly along with Bronco to operate the infusion system. You obviously have to have a RAM, EKG, some of the other, ancillary equipment in your lab. One other program that is sort of an add-on to the Cardionics program that I really like is the equipment upgrade financing option that we have. And so what you have a lot of times when you buy a PET CT is it's got all the bells and whistles for oncology. It might have some cardiac on it. Most of the time, it does not come equipped to do gated cardiac perfusion. So in that case, you go back to your OEM, see how much the upgrade is, and go through all of that process to get the system upgraded. Understanding how some of the budgets work nowadays, particularly in hospital systems, that can be a long, drawn-out process. Maybe you don't even have the capital spend available to make the upgrade. So you're kind of not able to get into PET from that standpoint. So in order to solve that problem, we partnered with some of the OEMs to offer an upgrade solution so that if you have a camera that needs the cardiac upgrade, you can upgrade that camera through us. It becomes a lease rather than a capital spend. And so we will upgrade the camera and you just pay it off over the term of your lease, over the term of your service, actually. So it's a really nice option, particularly for IDTFs or health systems, again, that already have the camera and don't want to shell out what can sometimes be substantial costs to upgrade the system. All right. In summary, so CDL Nuclear, we're here to help you get into cardiac PET in any way that is most appropriate for you and your practice. They're always custom solutions. If you need a camera and you have the space, we can certainly put one into your lab in a fixed site. We can also bring a mobile camera on a trailer, as you see there. If you already have the equipment and the staff, we can bring in the rubidium only with CardioNavix. Thank you all very much, and we'll open it up to a Q&A.
All right, everyone. Thank you, Dr. Dulcizian. Thank you, Brendan. Appreciate the presentations. Now we're going to open it up to the Q&A. As a reminder, you can still submit questions by clicking on the Q&A button at the bottom of the screen. We have a few that are coming in. The first one, Brendan, I'll kick this to you. Does CDL offer services to Canada or have a Canadian contingent?
We don't yet, but we certainly would like to. So we're open to that. Don't hesitate to reach out.
All right, very good. Brendan, another one that came in, this is probably geared towards mobile rubidium. What is the typical time from startup to first patient?
That's a great question. So it depends on what your licensure looks like. If you already have a RAM that has rubidium and strontium on it, or if it's just got a broad scope for high energy isotope, you can actually get started up very quickly. Then it's really a function of how soon we can get the trainers in there. And they range anywhere from like 2 to 4 weeks. So I would say in that case, maybe figure on 30 days. Obviously need a RAM amendment. That's going to take longer. And since COVID, that process just has slowed to a crawl in some places. I see 30 days. I see 90 days in some states. So that's going to really be your limiter.
Great. This is one regarding lead shielding. Dr. Dulcizian, if you have a comment on this, feel free to chime in. Brendan, you may have some suggestions here. I've been given what I consider a very expensive quote for shielding. What options do I have for confirming if this amount of shielding is necessary for PET only?
Well, those are tough questions. I usually have our physicists actually involved to make that judgment, because it does require physicists to make the quantification and calculation and meet the guidelines that's required in your own state.
Yeah, short answer.
Thank you, Dr. Dulcizian.
Is check with your physicist. I will say, you know, the OEMs also have kind of a standard config with a radiation diagram on it that you might consult. But, you know, we typically at CDL, we do what I call a LARA plus. So we don't take any chances with the radiation. And I know it is expensive. We build out a lot of labs and the cost of lead shielding has just gone through the roof. So I'm sympathetic to what you're going through.
Brendan, we have a few questions, it looks like, on the mobile rubidium. What is the cost to bring the generator in for a day, and how many patients typically have to be done in a day to cover the cost?
Good question. So I don't want to sound like I'm punting on this, but I mean, we do want to get in there and talk about what the appropriate frequency is for you in your practice based on your volume and based on the workflow. I will tell you that the break even typically ends up somewhere around like 2.5 patients in a given day.
Great. We got a question out of Maryland. Does CDL provide services in Maryland?
We do. Yep. Maryland's one of those states that I mentioned you actually have to do a PET unless you are a radiologist-owned group, then you can do PET CT, but we absolutely do have systems in Maryland.
Right. Another one on CFR. Can I do CFR with your mobile camera?
Yes. Yeah, absolutely. They, again, brand new systems, all outfitted to do CFR. As Dr. Dulcizian explained, CFR is a really important adjunct to the perfusion image.
Okay. How long, another mobile, it looks like, how long does it take to start a mobile program? Brendan?
Well, it's typically quicker than a fixed site program, but it does depend, on siting and licensure and those sorts of things. As far as the availability of the mobiles, we have enough on hand. I feel confident to say that we could start you up whenever the site is ready. If you already have a pad and a hookup, for instance, then it can be a pretty quick turnaround time. If you need those things, then again, we'll send a project manager out there to sort of evaluate the site. And if you elect to look at a partnership, we'll run the show to get a pad poured and power sited there. So that can take, 3 to 4 months, something in that neighborhood.
Okay. Another mobile trailer question, Brendan. Are they leaded, and are there any other external requirements needed?
They are absolutely leaded. The external requirements will depend actually more on the township or the city that it's in, more so than any kind of federal or otherwise requirements. So, some of them you have to, build a pergola underneath and cover it with vegetation. Others you just pull up and do your patients and away you go.
Dr. Dulcizian, I think I'll kick this one to you. This is with regards to a saline flush. Do you recommend a saline flush after rubidium injection? If so, how much do you recommend the tech go in and flush immediately after injection?
I have to say that I don't know if our techs actually do that. We follow whatever we have a Bracco equipment, rubidium generator, and I don't try to change what the FDA approval and recommendations are. So we just follow whatever the generator manufacturer is recommending.
Perfect. Do you need a time of flight PET CT for optimal CFR evaluation?
Well, the time of flight, as you know, is a huge advancement in both image resolution and counts, and most of the advanced PET CT technologies, I'm sure CDL is purchasing now, does have that capability of time of flight. And so I think that, again, for quantification purposes, our physicist, Mark Smith, has looked into this and definitely improves the reproducibility of quantitative absolute blood flow data. And I'm suspecting that, again, most of the current PET CT machines out there are already moving in that direction. The only ones that I may not have are the old refurbished PET cameras that you may purchase. But I think that any current standard PET CT machine will have the right time of flight.
Great. Thank you, Dr. Dulcizian. Brendan, is the CardioNavix mobile rubidium generator available in all states?
It is. Yes. Yeah. We are licensed in the entire country at this point.
Right.
So Phil, I just want to make a point, just from clinically, I just want to let the audience know that if you are transitioning from SPECT to PET, I just want to let you know that there are certain patient populations which you didn't even get referral for, you're going to be getting them. For example, the heart transplant population, where you're looking for vasculopathy, and these patients go to the cath lab annually to see if there's any change in the coronary vessels. Now we're getting all of those patients referred to rubidium PET, because by measuring absolute blood flow, we're able to monitor any vasculopathy, whether it's coronary artery narrowing or diffuse vasculopathy, and year by year you can see if it's stable or it's going downwards. And again, I think that that's something that you could not possibly have done with SPECT imaging.
Thank you, Dr. Dulcizian. We're going to add one more with regards to mobile trailers. Is it available in Arizona and Southern California?
Yes. Yeah, absolutely.
Right. I'm just seeing if there are any other questions coming in. And it looks like That is all of them. All right. Well, if there's no other questions, I want to thank our presenters, Dr. Dolcizian, Brendan, and certainly Yasnik for making this webinar possible. And thank you to all of our attendees for taking time out of your afternoon and evening to join us. If you would like more information or have additional questions, please contact your local CDL sales representative or email us at info@cdlnuclear.com or visit our website at cdlnuclear.com. On behalf of CDL Nuclear and our presenters, thank you for joining us and have a great rest of your evening. Thank you, everyone.
Thank you.
Thank you.